So this morning we are doing pressure diagnostics, pressure assessment, and pressure dynamics. What this goal is to teach you how we monitor pressure. Now, this lab is, at one point in time we did this lab and we hooked pressures up to different tubing and things like that and measured pressure off the heart and lung machine. That was a little bit down the line without first understanding and knowing how to set pressure up and how to measure it with a monitor and things like that. So we've kind of switched this a little bit to more of a pressure system setup type of a lab. And then we're going to progress this semester to where we use the setup that we do to measure pressures on different devices, ECMO, heart and lung machines, and off of vessels and things like that eventually with pig labs, right? So the first thing we need to do is understand how pressure works. Pressure is measured by a pressure transducer that is connected somewhere to a vessel, which could be extracorporeal circulation tubing, or a vessel in the body that converts a resistance across a membrane to an electrical signal. That electrical signal is called a piezoelectric signal that converts here in the transducer via a Wheatstone bridge. Remember that Wheatstone bridge to a plug-in that then goes to a monitor that gives us a readout in pressure on a continuous line. So piece metal signal, Wheatstone bridge, piezoelectric. So there's a signal in here and it converts the pressures on two different sides of a membrane to an electrical signal. That's how we get a pressure number and a pressure readout. That allows us to hook it up to a monitoring system. So the way these work is we can have external monitoring system in the OR, or we have one here. We also use these on our heart and lung machines. So we can measure cardioplegia pressure, an arterial pressure, a venous pressure. We can measure as many as 3 or 4 different pressures using the heart and lung machine, kind of whatever we set that up to do. The same thing goes with a patient in surgery. This is a single transducer, and we're going to open this up in a minute. These come in single, double, or triple transducers. All that is a simple way of deciding how many pressures you want to measure. So if we have a Swan-Ganz catheter in, we're going to automatically need how many pressures? 3, right? We're going to measure our arterial pressure, our venous pressure, and our PA pressure, our CVP, our PA pressure, and arterial pressure, right off that. Okay, what if we are measuring our radial pressure and then we need to put in a femoral line? Well, we can do 2 things. We can grab a single transducer, or sometimes I will kind of jerry-rig it into where they all come off the same pressure bag, and we actually have 4 transducers on our Transducer Clip. These things hook, this one obviously only has a spot for 3. You'll have, most clips have a spot for 4, or some even 5. Behind Zoe over here, there's a clip with 4 different things, but it's just, the clip is where you hang the transducers. So we can measure as many as 3 or 4 different pressures at a time, given whatever the heart and lung machine is set up for, or whatever the monitor is set up for. So again, there's a pressure tubing that comes down off of some catheter or off of a piece of our tubing. What do we want? Do we want very large tubing with thin walls, or thick tubing walls, or small tubing? What do you think?
Probably
thick wall tubing, so it takes the elasticity out, right? Because otherwise it will dampen the pressure. Long tubing, short tubing, big tubing, little tubing, what do you think? Pressure tubing, what's pressure tubing like? Very thick walled and very small, right? Very small, because the larger the tubing, or the more flexible the wall is, the more that pressure will be dampened out. There are other things that dampen that waveform. Air, clot, a low pressure in the pressure bag. A lot of different things can then dampen that pressure. Another thing that dampens the pressure is giving in a vessel, or in the vasculature, would be giving too much phenylephrine, or some kind of vascular issue, where the vessel itself becomes either too elastic or so constricted that we don't get a good pressure measurement. Sometimes coming off bypass, not having volume in the patient over a period of time, especially smaller vessels, get dampened. So once you fill the patient back up, the waveform gets less and less dampened. And we'll talk about that and show that later on, and you'll be able to see that. Where do we measure pressure off of our patient? Where's the most common place that we measure arterial pressure off of our patient? Anybody know?
Radial.
The radial, either the left or right radial, depending on the case. The radial has very good access. You use an arrow catheter, you put that catheter into the radial artery. I personally have done thousands of radial artery insertions for pressure at the heart hospital there. We would insert those lines. Then you connect a hard, rigid pressure tubing. From that, it goes then to our transducer here, plugs into the monitor, it gives us a pressure reading. There are other places to measure pressure as well. Generally speaking, the further proximal you go towards the heart, the larger the vessel, the better pressure reading we're going to get, because the less likelihood that that vessel is going to be dampened. Does that make sense? So if our radial pressure is dampened, you'll see a surgeon or an anesthesiologist once in a while put in a brachial pressure line. Even better than that, oftentimes they go and put a femoral line in because of the access, and it's big, and it has a great big vessel there that's not as easily dampened. It gives us a better pressure off of our femoral artery than the smaller arteries as we move down the line. Some people say, well, why wouldn't you just put a femoral in right away? There's a surgeon, Dr. Geist, in Iowa and Illinois. He puts a femoral line in every single patient because, like, oh, every single patient I have, the radial line gets dampened, so he puts in a radial line and a femoral line. You'll have other people say, well, that's overkill. You're going into a major vessel. It gives you a greater chance for infection and different issues that come with repairing that vessel. So some say it's overkill. Different trains of thought. I will ask you one thing. Where, knowing your anatomy and physiology, where would be the absolute best place to measure pressure? What's the biggest vessel where pressure is generated?
Aorta.
The central aorta, right off of the heart, right? Well, guess what we have, or not us, but the surgeon puts into the central aorta? The aortic cannula, right? Okay, so now we have a big cannula right in the central aorta. It allows us to clamp our perfusion tubing proximally in our system to where the pressure is being monitored. So if we clamp between our pump and where pressure is monitored, now we're reading pressure back on our heart and lung machine right off of the central aorta, right off of our aortic cannula. And we'll look at that this semester and see that, and you'll see the difference, especially with pig labs. When we get there and we have our cannula in an actual pig, we will compare the radial line pressure, or for the pig, it's actually a femoral vessel, with the central cannula pressure, and we will find that mean, and with the heart and lung machine, we don't get pulsatile pressure, we just get a mean pressure. We'll compare that mean, and we'll find that mean off the central aorta is probably 10 to 15 points minimum higher than what that radial pressure will be, just because that vessel is so much bigger and gives us such a better pressure. Does that make sense? Given though also that the elasticity of our tubing does dampen that pressure a little bit, it will still be higher and better. So that's a little bit of an idea of how we measure pressure. Let's talk a little bit about how we set up the devices and the disposables to measure pressure in the first place. That makes sense? The first thing you will need is a fluid. The most common fluid on a transducer would be heparinized saline. Heparinized saline. Why? Well, these transducers are made that every once in a while they submit a drop of fluid to keep that catheter open. Heparin obviously will keep that catheter from being clotted off, mixed with the pressure in the bag, which we're going to get to just in a second, will flush that catheter, that arrow catheter in the vessel, and keep it from clotting off. That's number one. In the last 10 to 15 years, something has arisen where it's caused a lot of practitioners, especially people who really understand physiology and are really kind of in tune with things, to go away from using heparin and just use saline. What would that be? What do you think that would be? Have you guys heard of heparin allergies or heparin-induced thrombocytopenia? That comes often from an exposure to heparin, correct? Well, if I'm going in to do a case and that we're going to measure pressure, but we're not going to give that patient heparin like we do on a cardiovascular case, but the patient's getting older, and we put in a catheter and we use heparinized saline, that's a heparin exposure for that patient. Now, 10 years down the line, they need heart surgery or they need a carotid or something like that. Now that patient has had a previous heparin exposure really for something that they didn't need that for. So they have a much higher ability or a tendency to have a heparin allergy. So we've tried to save these patients that initial heparin exposure, and we use regular saline. Now, does regular saline work as well as heparinized saline does? Not as much. So you have to make a conscious effort to flush that transducer once in a while, especially when we do blood draws or things like that off of that transducer. Make sure that we rapid flush that until it's all the way clear. Some people even draw some fluid back in a syringe and make sure that they flush that, and even check all the way under the drapes to the arm to make sure that line is completely devoid of blood and flushed with clear fluid, so we don't get the transducer setup and the catheter to clot off. That makes sense? So we limit heparin exposures, but the most common form is still heparinized saline. Saline is making a big run. What we aren't going to use are Plasmolite, Normasol, things like that, because those have all the electrolytes and things added, right? So we don't need that. Saline is super cheap, 99 cents a bag or whatever it is, super cheap and super easy to use. So the first thing we'll need, Zoe, behind you is a pressure bag on that pressure monitoring system. Would you hand that to me?
Yeah.
So the first thing we'll do when we set this up is we will need to put this into a pressure bag. A pressure bag looks like this. Now, a couple things about the pressure bag. Somewhere on these, a lot of times they will say for single use. Don't use these for single use. Do you guys think people throw these away after every single use for the most part? I'll tell you, you'll be at a hospital and they see you throw this away after one use, they'll get on your case, because these are a little bit expensive for something that gets thrown away every single time. When do you throw these away? You'll throw these away if once they start to get ripped a little bit here, or if you see them visibly soiled in any way. Generally, are these around anywhere where they deal with patient care? Generally, they're off and away from the table, or maybe you'll have one of these on your blower mister that's on a column where your CO2 comes for blowing CO2 into a valve or the chest or things like that. They're not really close to a sterile area. So the bag of saline goes into this pressure bag. Now, some of these pressure bags have a little hook inside to put these in, others don't. Some people don't hook these bags of saline into these pressure bags at all. I will give you a little bit of a hint. If there is a hook in there, the hook is right here in the back, hook the bag over that hook. Or another cute little deal to do with this pressure bag is when it just has this hanging tag on it, loop that hanging tag through our saline. Let's look at him, tight one. It's great for the video. Look at him struggle. Look at how much he's struggling to put that bag in. So what I'm saying here is we have the opening for the bag and we have this loop. Some people will just hang this and then blow it up. What do you think is going to happen a lot? This is going to lose pressure, and what's going to happen?
Fall out.
It's going to fall out. Well, how happy is the surgeon once that falls on the floor or bangs into an instrument tray or something like that, and really upset? So a little trick of the trade is take this loop, put it through the bag itself, and then hang it like that. That way, even if it's hanging and there's no pressure on it or anything, it's still going to hang and that's not going to fall out. See that? Okay, so the next thing is we have that in there. We have a built-in pump to pressurize that. Anybody know how high of a pressure we need to pressurize that to avoid dampening and so that still flushes? Any idea what the pressure will be? About 300. About 300. Why do we want to pressurize this to 300? It needs to be well above something. What does it need to be well above? Our patient's systolic pressure, right? Some of these patients that we have in cardiovascular surgery, they take a lot of drugs to keep their blood pressure down, don't they? Well, guess what drugs they don't take a lot of times right before they come into surgery? Those same drugs, right? And so when they come into surgery, it's not uncommon for us to see systolic pressures of 180, 200. I've seen as high as mid 200s or higher. So we want to keep this at a minimum of 300 pressure or greater. Now, one of the cool parts about these bags, they make it very foolproof. Watch what happens. Watch what happens. It's like keep pumping, keep pumping, keep pumping, keep pumping. Look, it's labeled. It's labeled on there, 150, 200. All at once, we get into green. It goes from white to green.
Wow.
Why would they do that?
That's probably 300.
So you don't make it explode?
See, number one, well, guess what happens? Guess what comes after green?
Red.
Can you see it in there? Can you see it in there? That what comes after green is red. What's another thing? What do you think? Eiley, I'm going to try to stump Eiley. Eiley, since that's green over there, and I have this hanging over on a column, what can you as the perfusionist or somebody do to quickly check? I guess I kind of gave you the answer.
Yeah.
You're going to get this right. You're going to for sure get this right now. So if we have this hanging over on an IV pole or someplace hanging on a column where our CO2 is going, we can look and see at the bag without going over and feeling it and checking. Yeah. Oh yeah, it still looks like 300. You can look and see that it's still in the green, which means it's high enough. We also have this when we set up the balloon pump, right? We have one of these transducers for the balloon pump. We have to set up a single transducer for our balloon pump to measure pressure same way. So you can look at your balloon pump and see, oh yeah, we're still in the good. We're not in the red, we're still in the good, which is 300, give or take 40 or 50 either way, still are in the green. Okay, here's another trick of the trade. The more these pressure bags are used, the less likely this whole thing will hold pressure over a period of time. Usually, it's in this bulb and this part of the tubing. So what the smart thing to do is after you pressurize this, always turn the stopcock off to the bag. Now it holds that pressure and the pressure doesn't leak all the way through. Does that make sense? Pretty easy thing to do. It will just save you a lot of having to get up and go repressurize your bag over and over and over again as these bags get used over and over and over again. A lot of times, perfusionists are responsible for setting up the pressure transducers. At the Heart Hospital in Lincoln, we did all of the pressure transducers, doubles, singles, triples, whatever the cases were for the next day. That way anesthesia could come in, grab what they need, go take them to the patient, put in lines, or the cases in between to make things efficient, we would set these up and get them ready. Is it hassle? Yeah. Is it tedious? Yeah. Sometimes you have respiratory therapy or anesthesia assistants that do it or things like that. What was good for me is it really taught me how these things work. And it got me exposure to using these systems and to figure them out. So that when I'm drawing samples or things like that in different kinds of cases, I really understand how the thing works, or I can see, hey, I need to blow it up and things of that nature. That's why we go over this for you too, in case you go to a place where it's your responsibility to set these up. Maybe some of you have in previous jobs or anything. So, bottom line is, we've got our bag right here and ready to go, right? Steven, come here. You're my IV pole, right over here. So since you're so tall, Steven's IV pole. Now, normal fluids running in, does that matter how high or low we put it on an IV pole on normal fluids?
Not really, as long as it's above.
Okay, on normal fluids without a pressure bag, the higher you put that, the more gravity is going to affect it, which means there will be a greater difference between the pressure of the patient and the height. So you'll see anesthesiologists once in a while, if they're giving blood or giving a fluid, that IV pole will be up, they have to stand on a stool to get up and get their fluids and things like that. Will it affect one like this with a pressure bag? Probably not. We'd have to have a pole that reaches all the way up to the 8th floor before we would overcome the pressure in that pressure bag or make any difference, right? So generally, once we have a pressure bag, the IV pole is not going to matter. That being said, I chose Steven because of his height and good looks, right, Steven? All right. So, IV pole, can you do two things at once, you think, or no?
I don't know, it's a lot.
Let's try this. Generally on the IV pole, there will be a transducer clip as well. So, let's raise this just a little bit so it's always higher, just in case the pressure isn't. I'm joking. Your arm's gonna die. So our IV pole, our IV pole has this already set up and going. So the next thing we're gonna do is, so we've got our bag ready to go. We're gonna find our transducer. This is a single transducer. The only difference between a single transducer and a double and triple transducer is how many of these things, which allows us to measure pressures. If it's a triple transducer, we have one bag spike, it comes off, and then that fluid Y's into each individual transducer. It Y's off into each individual transducer. A single just has one. That's the only difference. So here is our transducer. Here is the fluid spike. The transducer will fit in a clip. Of course, we probably have a different clip than what this one shows. Usually there is a direction of flow on the transducer. If you look behind Zoe, there's a clip, there's a couple of them set up. You see how they're upside down, Zoe? To where the top of it, yeah, maybe bring that one over here. Maybe bring that one over here and we'll give it to our IV pole and we'll show that one instead. So I'm just gonna take that transducer set and I'm going to use one of these, and male to male here. I'm going to set this transducer up here. So now our spike will go into this transducer. Eileen, grab me one piece of pressure tubing here, would you please?
Okay. You want like one of the little yellow ones?
Just any pressure tubing, perfect. Yeah, this should work. Nope, this should work perfectly fine. So we'll use this one. So these transducers are all different. They all have different plug-ins for pressure. For instance, when you see these two different ones, you'll notice that they're completely different plugs. Why would they have different plugs? Because not everyone has the same monitoring system, right? So you have to order the transducers that match the plug-in to the monitoring system you have, or the heart and lung pressure cables that you have that connect to your heart and lung machine for perfusion. So this particular transducer will plug into the monitoring system that we use. So if we're using this as a double transducer set, this line here will Y into both of these. Or if there's 3 of them, it will Y into all 3 of them. Like I said, if you want to add a single one but only have one pressure bag, so you could measure 4 pressures if you have radial, femoral, CVP, and PA, you can even jerry-rig with another male-to-male corrector and Y off even another one. It'll come off with the stopcock and then Y into your 4th transducer. I've seen as many as 5 or 6, all wide, like 2 triples, all wide off of the same pressure bag. It kind of looks like spaghetti and kind of a mess, but then you only have one pressure bag that you need to move from IV pole to the bed and back and forth, and one big transducer system with 2 clips. Anyway, so this transducer IV pole here is now all ready to go. So we take the fluid spike and sterilely pull this off. Spike the pressure bag. Oh,
it's spraying.
so it looks like this one might be, we might have a hole in that transducer.
Even you
So
deserve a gold
give me a
globe.
clamp there. Give me a clamp behind you, will you please?
Here, I got him.
So,
Stop!
so I'm going to clamp this
I
one
get
here.
him.
So it looks like we have a pin-sized hole in this transducer, doesn't it? So what we'll do is, since we have another one right here, we'll move this over and use this other one. I think we should probably also, let's throw that one away, just so when we get to pig labs and have blood. Should we leave the last class? Leave the next?
Yeah.
Let's not. Let's throw this one away, knowing that we are eventually going to have some blood.
I'm gonna take that with me to my rotation and use it.
Some blood in that one, and we don't want to get that. So now we're ready to go. Let's try this again.
Take that clamp off.
So we'll open this up. We'll pop this clamp. Now it's holding pressure. Okay. Here is how we set this up. Notice, there's no fluid coming out of this, is there? But each one of these transducers have a little device on here you can pinch. Some of them have a pull or things like that that you can pull or fast flush these. Pinch or pull, depending on the cap. This is a non-vented cap, so you can fast flush this. Now, as our colleague over here, Scott Sanderson, might do when you're flushing one of these, if you have somebody that is really kind of an arch enemy and you're flushing your transducer, you can use this as a little bit of a squirt gun. Or if I was Scott's partner and Scott had really gotten me upset that day, I might just, while I'm flushing this, just stick this in Scott's back pocket, maybe, and then pull or flush this a little while. I might run it a little bit extra on a fast flush, so that when Scott's up at the table, maybe he's the scrub tech or something like that, starts to feel, I don't know, that feels a little funny, right? Something's running down my back. No, I don't suggest that, obviously, I'm joking, but so that will fast flush out and through that pressure transducer. At that point in time, once it's all the way flushed through and there's no bubbles, then we can take that line and connect it to our aero catheter, either from our femoral line or our radial line. Plug this into our pressure monitoring line, and we can then measure a pressure. Anytime we draw a blood sample off of here, we'll want to draw enough back with the previous syringe so that this is complete blood, so it's not diluted. And then we'll want to flush that all the way back in. A lot of times what I like to do, just a quick thing, I'll pop my syringe out, and then there's always a little bit of blood left in this little device, in this little part right there, right? And every single time you take that on and off, kind of gets your syringe messy, your gloves. I'll either pull off my glove and run a little fluid out of that, or into my glove, or I'll use that syringe wrapper that the syringe came in, and I'll just flush that into the syringe wrapper so it doesn't run onto the floor or anything like that, and then throw that away. That's just a little trick of the trade. Everybody see how that works?
Mm-hmm.
Stephen, you can just hang that on that IV pole there for right now, and then we'll use it in the next lab group. Any questions about how a transducer system works and how we get it ready and how we set that up? Again, you can measure as many as 3, even 4 if you bring in another transducer, but they make single, double, and triple transducers depending on how many pressures we want to measure. The heart and lung machine is set up for 3 different pressures. We need to have that pressure bag at all times above that 300 in that green. Once it gets less and less, it will dampen our line. You won't see it as good because it's not enough to overcome the pressure in the patient. That makes sense? Everybody get to see that? We can hook these up to any pressure in our patient. We can also then hook that up to anywhere in our circuit and measure blood pressure off of our circuit. What do we use off of our circuit to measure pressure? A pressure dome, right? It gives us that membrane to measure pressure across and things. So we use a pressure dome on our bypass machine. Any questions? All right. Okay, so we have to also understand and know the difference between zeroing and calibrating these pressure transducers. So calibrating a pressure transducer or calibrating a number is essentially setting a device to a normal or a constant, so that way we know that the numbers we're reading are actually correct. Whereas zeroing is creating an absolute zero according to atmospheric pressure or things like that. To zero a pressure transducer, we would want to open the pressure transducer to atmosphere. So we would take it off to the patient, open it to atmosphere, zero it exactly even to where the left atrium of our patient is. Why the left atrium, or the heart essentially? That's where the major volume part and the pressure is being generated from our patient. If we've zeroed this pressure transducer and then the pressure transducer is lowered compared to the patient, we will get a falsely elevated high pressure. If we raise the transducer in comparison to our patient, we will get a falsely low pressure. So the pressure is only accurate when it is completely even with the patient. A time when this might have an impact, raising or lowering the bed during taking the mammary artery, or if we are moving the patient height versus our transducer height at any given time. Obviously, kind of a trick if the surgeon is upset that the pressure is way too high or way too low for a given time before the drugs can work, you can always slide that pressure transducer. It's kind of a trick to trick the pressure, trick the monitor into seeing a different pressure. We obviously don't advocate that, but you can quickly manipulate the blood pressure simply by moving the transducer and the pressure clip up and down the IV pole. It can also lead to problems if, say, the transducer is really high and we're taking mammary and then the patient's bed is removed. Well, now it looks like the pressure is low, even though it's a false low, so we're treating a false low pressure when all we would have to do is bring the transducer down. So that's where and how the zeroing and the pressure transducers should occur.